Hi, welcome. I'm Rami Khouri from the Media Studies program at AUB, and I'm glad to welcome you to another episode of our weekly program from the Beirut COVID-19 briefings from AUB. We're going to talk this week with a professor who probably knows more about this virus than most other people in the world, and she is Associate Professor of Infectious Diseases and Microbiology, Melhem, and she is at the Faculty of Health Sciences. She wears many hats. She's on the AUB COVID-19 Expert Committee, and she is chair of the Medical Laboratory Sciences in the Faculty of Health Sciences, and her specialty is virology and immunology. So she spends all her days and nights looking at viruses. I exaggerate, but tell us exactly what you do. But first, let me just mention we have Alison Freeland in New York, who works at the AUB Director of Communications in North America. Alison will host the questions and comments that come in from our audience.
Thank you, Rami, and I just want to remind our audience that if you'd like to ask a question, you can post it on the Facebook chat, and we will get it to Dr. Melhem. Thanks so much, and we're looking forward to this talk.
So as a virologist and immunologist, this is like you hit the jackpot studying this incredible problem that we have with the COVID-19.
Well, it's a new virus, and every few years we have new viruses coming up and coming around, and yes, they keep us on our toes. So now this is the main subject of study, and we are all involved in this fight against it.
And do you find that every new virus is completely new, or is it just a mutation of an older one, or do you have to start from scratch to study it?
Well, we have what we call emerging and re-emerging infectious diseases or viruses, and when we talk about re-emerging, these are similar strains that have parental origins, and then we have modifications to them that we are seeing. With SARS-CoV-2, which is the causative agent of COVID-19, this is a new virus. And because it's a new virus, we don't have any treatment for it, and we don't have any vaccine until now for it. And this is why our immune system was vulnerable, and we were vulnerable to infection and disease, and this is why we have this large pandemic hitting across the globe.
So if you look at the work that's been done in your lab, across Lebanon, the Middle East, the world, I know you exchange information with scientists on a daily basis all over the world. What would you say is the most significant thing to date that scientists know about this virus? So,
since the beginning of this epidemic, and then when it was declared pandemic, until now, we are learning every day something new. And something new about the clinical presentation of caused by the disease or by COVID-19, something known about the virus. And the most important thing that we learned across the way is its high transmissibility and its ability to be highly transmissible. This is one of the key factors actually that we study when we study epidemics and pandemics. And a characteristic of SARS-CoV-2, or the causative agent of COVID-19, is it has a basic reproduction number that is defined as the number of secondary cases caused by a primary case to range between 2 and 3, which means if one person is infected, it is going to cause an infection and it's going to be transmitted to 3 others. And this is higher than what we have seen with influenza, for example, which is also a respiratory disease causing a respiratory illness similar to COVID-19. So this is one of the things that we learned about COVID-19. Another important thing that we've learned recently as well is that asymptomatic individuals, people without symptoms, or pre-symptomatic individuals are capable of carrying the virus, and consequently they could be huge drivers of transmission. So every single day we're learning something new.
So how do you physically go about studying the virus? It's a microscopic organism. So can you tell us in layman's terms?
So we have many methods, and some of the methods are like microscopic measures and methods whereby we are able to either stain or put a dye on different components of the virus, and then we can see them under the microscope. We can see them real time as well moving. There are other ways by which we can study them and determine their clinical course by using some proxy measures or correlates measures. And you know, there are many parameters that are in each side of the scientific domain of viruses.
And do you, for every person who comes to AUB or other hospitals who has the virus, do you take a swab and that's how you get it? You
Yes.
physically scrape it out of them?
So the specimen of choice until now, because this is a respiratory, this is a virus causing a respiratory disease, the main specimen or specimens that are being collected are nasopharyngeal swabs or oropharyngeal swabs. And these are mainly what are being used in order to test by a molecular method that we call RT-PCR in the lab. Of course, we have other methods that we are exploring other than the molecular methods, and you know, we're going with that.
And we read in the media, we hear in the media that maybe it's mutating, they're possible. What's the latest scientific evidence on that?
So the SARS-CoV-2, or the causative agent of COVID-19, belongs to a family of viruses that we call coronaviride. And this is a family, the genomics of this family belongs to RNA viruses. So SARS-CoV-2 is an RNA virus. And RNA viruses, by nature, have an exceptional plasticity to mutate and to evolve.
Wow.
And when these RNA viruses, whether coronaviruses or other RNA viruses, mutate, sometimes these mutations affect the behavior of the virus or its tropism to certain cells or tissues, or its virulence, which means the ability to cause a disease. In that case, you know, this is when we have a tricky model for vaccination, because these mutations will dictate the strategies that we would use for vaccination, for example, as well as therapeutics. Now, we are lucky that until now, what we know is that SARS-CoV-2 mutates approximately 1 to 2 times per month, which is 2 to 4 fold less than that of influenza. So it's relatively stable, which is great. And this is good news for vaccination. But we also know that we have approximately 8 circulating strains across the globe. Now, while we have 8 circulating strains, this means that they have underwent certain mutations, but these mutations until now are actually minor genetic modifications that differ between these strains that did not alter the behavior of the virus, and consequently, we believe until now that a single vaccine would be we would be able to generate a single vaccine that would hopefully confer, a long-term immunity, rather than doing what we do with influenza. Because of the changes in the viruses, and because our immune system does not actually recognize these new versions of the influenza strains, vaccines for influenza change every single year in order to accommodate the strains that are most predominantly circulating, and this is what we put in influenza vaccines. Until now, we are lucky with COVID-19 and SARS-CoV-2, so it's relatively stable.
And there are literally hundreds of scientists and labs around the world trying to find a vaccine.
We have a huge number of clinical trials that have been registered, more than 300 actually, and we have more than 56 of these that already have started. I hope I'm not mistaken with the number, but they are huge, and they are at different stages of the startup of the vaccine, and they have different platforms. So they target different components of the virus and the immunity.
And if a vaccine is going to take 6-9 months, whatever people are telling us, what does that mean for before that vaccine comes about, curative treatments? What's the latest on that?
So also we have hundreds and hundreds of trials on therapeutics or drugs. And again, they are at many phases in the process of clinical trials. Some of them are still at the preclinical phase, and others at the clinical phase where they are being tried on human beings, small groups of people. And we have many promising ones. I mean, recently we've heard about the remdesivir,
right.
and which showed, promising results in terms of clinical improvement, but they have to look at it into a larger group of people in order to confirm that finding. So the scientific community and the research community are actually active. They are active, all over the world in targeting both drugs as well as vaccines.
And is some of this work going on at AUB and in Lebanon, as far as you know?
We don't have until now any vaccine-related projects or therapeutics. But even though the medical community are trying another, as of last week, I'm going to allow myself to mention this. They have tried to use the convalescent plasma, so plasma from a patient that have been recovered from COVID-19, and they are trying it on other patients. So this is another strategy as well for treatment of
as a
disease.
short-term cure.
Yes, as a short-term treatment,
but not a long-term immunity.
No.
We have some comments, questions from New York.
Yes, a comment and a question. Some people online are noting that many AUB alums are involved in testing and trials in the United States and on the front lines in this. That's the comment. And then the question is there a difference in the lethal effect of the strains of virus? Is one strain more lethal than another?
So for COVID-19 and for SARS-CoV-2, these strains they have minor genetic differences, and until now the virulence or the ability to cause the disease or pathogenesis and consequently other adverse events in our bodies, they're not different until now. So we hope that we don't have any further mutations that would really change the antigenic profile of the virus and consequently our response to it, and probably the ability of the virus to cause disease. So until now, we don't have that.
And could we just ask how much you are connected with the trials that are going on around the world? Is there a network of scientists talking to each other all the time, or is it very isolated?
Actually, if anything we've learned in this during this pandemic is the importance of data sharing and the cooperation at having open data platforms. And for example, the genetic sequences of SARS-CoV-2, thousands and thousands of them that are isolated from all over the world are plugged in and dumped into databases. Scientists, we from all over AUB, we talk in different disciplines and across the board with our colleagues doing that. I talk every single day with my colleagues at the University of Pittsburgh as well as other universities, and I know for a fact that other individuals are doing the same in order to exchange experiences about testing, about contact tracing, about the best methods of testing and the best methods to read our results. And of course, the medical teams, they are continuously collaborating with people abroad in Europe and in the United States in order as well to offer and know about the best care and management of the disease.
If I can ask, I know that you're very active in these committees, and especially the AUB COVID-19 Expert Committee. I've attended some of the meetings, and it's quite amazing to see the intensity, depth, and variety of information that's coming in, like from 7 or 10 different quarters at once. You as a virologist, do you feel that this kind of interaction among public health specialists and medical doctors and other people who study this, is this proving to be a critical need, a critical way to help contain the negative impacts of this virus?
I mean, this is a great question because at the heart of strategic preparedness and for emergency preparedness and response is this coordination at all levels, at all levels of the research across the board, but also coordination at the national level, coordination, with surveillance units at the national level, coordination with national labs for diagnostics and tools, coordination as well, between us and committees, and bringing in the aspects that are present in the community and how do we mobilize our communities in order to respond. So if we learned anything is that the diversity and the more the stakeholders that are present on the table discussing of a pandemic, let it be the community, the communication, the risk management, the virology part of it, the public health infrastructure, the healthcare systems, the medical and the clinical aspect of it, the occupational aspect, all of this is really enhance to our understanding and equip us to better actually respond to and be prepared to emerging infectious diseases.
Is this the first time that you've seen this level and breadth of coordination on a medical issue?
We've seen during the influenza, the 2009 pandemic influenza, but now at this time, with all the advancement that we have, and we still have gaps that we've spotted, drew our attention and made us be alert that more of this coordination and at the national and the international level should be enhanced and strengthened. More building on response teams that need to be trained all over the world in order to be deployed, for example, to low resources countries. So we've identified some of the gaps that are needed, and now we are highlighting and pushing in our research activities and grants and funding proposals that we are submitting to actually try to work better at these surveillance system, contact tracing. The many nations, including Lebanon, we don't have enough national diagnostic labs so that they do the testing all over. So we had to train people in different areas of Lebanon. We had to deploy to certain labs tools in order to be able to test and proceed. So all of this is actually drew our attention to the need for a coordinated national and international collaboration at all fronts, including a community and participatory approach to mobilize them when we need them actually in the communities.
I wanted to get to that next. So now that the process in many countries, including Lebanon, has started to slightly wind down the clampdown, the closing up,
the lockdown.
People are going out a little bit more. You see them in the streets. Is this something that you're worried about, or is this being done in a way that you think is prudent?
So I'm going to address these two, this question in two separately. So easing the lockdown does not mean that the pandemic is done. Now, easing the lockdown, whether in Lebanon or globally, because many other countries are also implementing the easing of lockdown, right, in order to actually ease up on economies. So that's the main aspect that everybody is looking at. And however, this is not the end of the pandemic, and it's not the time to be complacent. We cannot be complacent. We have to continue. And I really stress on continue monitoring the trends of COVID-19 in communities by continuous testing, by continuous isolation and quarantining of individuals that are suspected of having COVID-19 or that got exposed to COVID-19. We have to continue on implementing the physical or the social distancing measures. We have to continue on wearing masks if we know that we are going to be in less than 6 feet or 2 meters from other people. This is a respiratory disease. This is a disease that is transmitted by droplets and or by these droplets landing on inanimate objects, and consequently we have this person-to-person transmission, but we also have this transmission through touching contaminated surfaces. So we also need to stress on the changes in the lifestyles and the habits, and the continuous practicing of the daily hand hygiene, washing our hands with liquid and soap for at least 20 to 30 seconds. And if they're not available, then we use hand sanitizers. So this is not the time to be complacent. So easing up the lockdown does not mean that we are done with COVID-19, but we have to continue implementing all of these public health measures and be vigilant at our surveillance, testing, contact tracing, isolation, quarantining, physical distancing, wearing masks. So all of these need to be implemented in order to monitor any change in the trends, because the key is to have a continuous, change in the number of cases and affected with COVID-19. And so this is not the time to be complacent. We have to do that.
Is there certitude or consensus among the scientific community about questions like how the droplets disperse in the air, how long they stay on plastic or metal or on your phone? Because I read different things.
Yeah.
What's the scientific evidence as far as you know it?
This is still a topic of continuous studies, but what we know from what is published is that this is a relatively stable virus, actually stable virus, not relatively, on inanimate objects and surfaces, and it could stay there from few hours to several days. However, it is easy to get rid of. So by washing and cleaning with soap and water, and then disinfection, this would make would every way to this will kill the virus on surfaces. So now to answer the other part of your question in relation to the measures of lockdown in Lebanon. And actually, we always have to compare or look at the measures of lockdown, but also what's going on in terms of the spread of the disease and the community transmission. And the first case in Lebanon was confirmed in February 21. And then since then, the Lebanese government has taken a number of actions. By the end of February, there was closure of schools and nurseries. And then by March 13 or 15, we had the declaration of the emergency declaration nationwide, and then March 18, the closures of the airport, which followed, the higher institutions, education universities also closed after that. The airport closed, the borders closed, and then this was followed by the complete lockdown. And when we look at the percentage of confirmed cases, and by percentage of confirmed cases, this is the number of confirmed COVID-19 cases that we have, divided by the number of tests that we are performing also in parallel with the isolation and the confirmation of cases. So from the beginning of the epidemic until April 6, we had a range of percentage of confirmed cases between 3% to 17%. Now, following the lockdown, and until now, so from April 6 until April 27th, when the Lebanese government decided to ease in phases the lockdown, the percentage of confirmed cases dropped to, and it's ranging now between 0.1% to 2%. Having said that, and I mentioned the date April 6 simply because on April 6, the Lebanese government scaled up the number of testing and the level of testing. And this is extremely important in order for us to be able to isolate and identify and detect cases. So from April 6 until now, we have daily at least 800 to 1,000 tests being done in order to detect COVID-19 or SARS-CoV-2. For example, today we had more than 2,000 tests performed.
Wow. I want to ask more about that, but let's go to New York first.
Yes, we have a question about how someone can be tested and come up with what they call a false negative. And they're wondering about what that indicates or how that happens.
So the method that we are using in Lebanon until now is RT-PCR. And this is a very sensitive and specific molecular method, but nevertheless, we could have some false negativity as the case with any other procedure. Now, in that case, a false negative has to be coupled with the clinical manifestation if a person is having a clinical manifestation. So the physician also would need to, even if the test is falsely negative, but the person has signs and symptoms, then the test should be repeated in order to confirm. Or and if it ended up to be negative again, there might be other types of viruses that have affected that individual. Now, having said that, and if we know that the person having some clinical manifestation with negative testing, we still ask these people to be in isolation and quarantine for 14 days, which is the incubation period of the virus, in order to make sure that we do not have still this false negativity of not having the positive test showing up. And then even after the 14 days, we also redo the test in order to confirm whether we have positive or still negative result.
There's also a huge effort around the world to come up with these small kits where people can be tested in half an hour or an hour. Yeah. What's the latest on that you can share with us?
So we have also many what we call them rapid testing, and we have also molecular rapid tests. So instead of waiting for a few hours in order to have the results of the RT-PCR, we have some rapid molecular tests that could give us the result in 45 minutes to an hour. We also have other types of tests that are antibody tests that are also that could be under the rapid testing. Huge battery of testing that is being released and daily either FDA approved mostly under emergency use, because the need of the field and the need of the medical community and the scientific community to be able to test as much as possible with less expenses in order not to weigh economies as well, because low resources countries do not have the luxury to perform molecular testing like RT-PCR, which is expensive. So this is why the scientific community and manufacturers are coming up with all sorts of rapid tests that less expensive. Like I said, many of them are under emergency use, which means that they would require validation. They would require that they would be coupled with clinical manifestation and observation, like I've mentioned earlier, in order to make sure that they are giving us the results that we want them to give us.
Do you anticipate there will be tests that people can do at home that will be scientifically reliable?
I mean, everything is possible. As a virologist, I really, don't favor these type of tests because there could be many changes that would affect the positivity or the negativity. Right. But yes, I mean, many manufacturers are working on these tests.
Yes. Tell us a bit about the ethics of this. If a company discovers a vaccine that seems to be successful, are they morally obligated to share it with the whole world for free, or they have a right to be able to make a lot of money out of it, or use it for their country only and then maybe others? What are the ethics of this?
Well, that's a huge topic, and I'm gonna answer with the parts that I know of, because So yes, manufacturers, they produce vaccines in order to make a profit.
Right.
But luckily, we have Gavi, or the Global Alliance for Vaccine Initiatives, that work hard actually under, this is under the Bill and Melinda Gates Foundation in collaboration with the WHO and other platforms. And, they have made possible the reach out of many vaccines previously to different parts of the world and to low resources communities and countries. And we would hope, if the vaccine is going to be that expensive, and for not all countries to have access to it, because access is very important. And until we have a vaccine, we still need to continue, like I said, exerting all of the public health measures that I've mentioned earlier. So the vaccine would be important for the fallout, or at least the beginning of the fallout of COVID-19. And access to the vaccine, like you've said, is extremely important. And universal health care is extremely important. So this is a lot of important issues that but we hope that it will gain access through the efforts of the global the Gavi, as well as other global communities, to make it accessible and affordable to many parts of the world.
And public health, as we now understand it from this pandemic, means universities, government, private sector, NGOs, international agencies, donors, and households. Everybody has a role to play.
Yes, I mean, like I said, emergency, and this is, now more than ever with this pandemic, the strategic, preparedness and response relies on every single person. And each one of us is a stakeholder. So in order to know what's happening in an isolated community, you need ambassadors to these communities, trained ambassadors to these communities on response and rapid response and tracing. Right. So you need risk communication individuals. You need, like we've mentioned earlier, the whole coordinated and all sorts of disciplines involved together: epidemiologists, virologists, clinicians, politicians for policies and policymakers, mobilizing the community, governmental organization and non-governmental organization. At the beginning of COVID-19, the Rafiq Hariri University Hospital was the only hospital that was, performing the testing for COVID-19. But then, this proved that needed extra support, and this is when the public sector came into actually being involved, and so on and so forth. So everybody is a stakeholder in this and any future pandemic or any future threat of a similar magnitude. And this is why the key is to prepare and be ready in order to learn from the lessons that we've learned here, in order to have a better coordination, country level coordination and international coordination at all levels.
Which is why we're going to go to New York and coordinate with our viewers.
Yes, I just wanted to tell you we have greetings and shout outs from Indianapolis, Montreal, Houston, Baltimore, from Syria, from Lebanon, and it looks as if there's a personal note to you, Dr. Melhem, from Dima Majoub, who says, "Miss you." And we do have one question. If you could address the expectation for a second wave of this virus and what you expect to see if that happens. And that's it from New York. I know we're getting close to the end here.
So, viruses in general, not only SARS-CoV-2, they go actually in waves. And the key to delay and mitigate and delay the second wave is to what we've mentioned earlier, to continue and not to be complacent, to continue using and implementing the fundamental public health measures of physical distancing, the wearing the mask to protect others, caring and protecting the vulnerable individuals, contact tracing, detection of cases, testing, continuous surveillance to monitor the trends of any surge in these cases. And this is specifically now more than ever when we are going into the easing of the lockdown. So we have more work to do now, and we probably need to think of, if we have a surge again, an unexpected surge, that we need to perform, probably or reinforce different measures of lockdown in order to prevent more cases and prevent the community spread of the disease. Now, until we have a vaccine that is capable of inducing immune responses, short-term or long-term immune responses, as well as herd immunity, then we have to be really vigilant and extremely vigilant.
And if we do get a vaccine and it's widely used and we get herd immunity, would this virus eventually just die away and not exist on Earth anymore? What happens to it? It becomes dormant?
It would be under control, similar to other viruses that are still around. We have many efforts to eliminate or eradicate. I mean, we've eradicated smallpox. Smallpox is a virus and is caused by a virus. We are in the process of eliminating measles, which is a virus. So we keep them under control and with zero number of cases. But influenza, is under control basically because of vaccines. So the role of vaccines is actually to keep viruses under control. Now, until we have a wide spread vaccination and more information about the duration of protection that a vaccine is inducing, as well as the type of herd immunity and the duration of that herd immunity, then we can start talking and discussing elimination measures and then not seeing that virus. So it doesn't die out easily. Not SARS-CoV-2, the causative agent of COVID-19, and not any other virus. Polio, we're still having a lot of, or exerting a lot of efforts in order to eliminate polio, and we still have some endemic countries there. So there's still a long way to go, but we can control it actually and monitor its activity.
We have time for just one more question. From this experience, how do you see AUB as a whole playing a role going forward, not only in issues like this pandemic? If you look at the issues of water and food, climate change challenge, women's rights, youth employment, these are multi-sectoral issues. They're not narrow, just sociologists or economists or political scientists or doctors deal with them. What do you feel now about AUB's importance in Lebanon and bringing together this extraordinary range of expertise that we have among our, I think, 700-800 research professors that can play a role beyond the gates of the university?
Well, AUB has always been important, regionally and internationally, and it will remain doing so, especially because, as we speak, and since the beginning of this pandemic, I can confidently say that we are working at many fronts in order to uphold and help upholding the national security and health security, as well as, and by upholding the national health security, we are upholding as well and collaborating and making efforts to uphold the global security. And we are doing it in different ways. So we have the research portion that, and as academics, this is our mandate. So we do research. We are every single individual, the faculties at large, so not only individual faculties are working on COVID-19 and applying for funding opportunities in order to help in this fight against COVID-19, but also the faculties at large. The schools are collaborating together in order to make personal protective equipment, to allow community mobilization, to study the virus that is circulating in Lebanon and the cases, to find the best way to debunk the myth about and to spread awareness. Gender and violence issues as a result of COVID-19, mental health issues, all of these are being studied by AUB. We have professional outreach as well and professional practice that we perform. And as you know, and you've sat with us, the expert committee has been very active in reaching out to locally and nationally. I serve on the National Committee for Communicable Diseases, and there is this dialogue continuously. Dr. Karine Saqar, the chair of the expert committee, the COVID-19 expert committee, and myself also sit on the task force under the National Commission for Chemical, Biological, Nuclear, and Chemical, Biological, Radiologic, and Nuclear Defense, where we are putting preparedness and strategies to be implemented ASAP. For preparedness and readiness for COVID-19 and similar threats. So faculties, individual faculties, research, working with the ministries, not only the Faculty of Health Sciences and the School of Medicine and us at the COVID, but also other schools. At AUB, they are working with the Ministry of Education and the Ministry of, for example, Industry, to work on the readiness of the personal protective equipment from the Maroon Sam'an Faculty of Engineering and Architecture. Right. I hope I did not miss anyone, but we are all doing things,
Well, it's food, agriculture, people studying refugee communities.
Absolutely, and the Faculty of Health Sciences, we're doing that. The Faculty of Agriculture and also Food Sciences and Agriculture, working a lot on food security, and so it's all across the board. And AUB will always be able to make the difference as it did and it's doing and it will do. Well,
thank you, Professor Nada Melhem. I think the virus doesn't have a chance with people like you and thousands of others around the world working. Let me just tell our audience that next week we're going to have Professor Simon Naimi, who is in the economics department. He's also head of the AUB advisory committee on finances and economics of AUB, and is an expert in the Lebanese and regional economies. And he'll be talking to us about the economic impact of the consequences of the pandemic and what this means for us and the whole region. So thank you for being with us. Thank you.
Thank you.
Professor.
Thank you for having me.
And we'll see you again next week.